behalf of the Australian New Zealand Society of Nuclear Medicine, it's a pleasure to welcome you to this live presentation of the Lowenthal lecture and the launch of session 3 of the On Demand program. My name's Karen Jones. I'm the TSIG rep on Federal Council, and it's in a few moments I'm going to be handing over to Professor Dale Bailey, who will introduce our Lowenthal lecturer for 2020, Dr. Cathy Willowson. Before I do that, I would just like to run through the, share that screen. I'm just going to run through the order of events for this evening's session. Dr. Willowson will present her lecture, and at the end of the lecture we will have an opportunity for her to answer some questions. During the lecture you are able to put your name in the Q&A box so that you can cue your question, and we will unmute your microphone at the end so that you can ask your question at the appropriate time. You'll also have the opportunity to raise your hand to ask questions at the end of the lecture. Following that, Professor Bailey will award Cathy with her plaque for the Lowenthal lecture, and the ANZSNM Lifetime Achievement Award will also be presented by Professor Bailey to Professor Vijay Kumar. Following that, we will then have the launch of session 3, the on-demand program, and any upcoming sessions will be discussed also. So I will now hand over to Professor Bailey, who will introduce our Lowenthal lecturer for 2020. Thank you.
Degree in physics at the University of Sydney, where she had worked on an undergraduate project with my colleague Roger Fulton. At North Shore, we had recently constructed our own hybrid SPECT CT system by bringing together a novel SPECT imaging system, the Skylight by ADAC, and a pre-loved single-slice Picker PQ5000 spiral CT scanner that we had purchased for a relatively small amount of money from one of the Dr. Jones and Partners practices in South Australia, and for which we are eternally grateful to the MBS and Capital Sensitivity. With this new tool, SPECT CT, Cathy created the first quantitative SPECT data using the CT scanner to perform corrections during the SPECT reconstruction for image degrading factors caused by photon attenuation and absorption scattering. But she did not stop just at showing this worked in anthropomorphic phantoms, and her thesis included clinical examples of validations of quantitative SPECT in lung perfusion and cardiac blood pool imaging with technetium radiopharmaceuticals. After completing her PhD, Cathy took on a postdoctoral fellowship funded by the Australian Research Council in a linkage grant with Certex Medical, and became the first to demonstrate that Y90 surspheres could be imaged quantitatively with PET in spite of the paucity of signal that is available from Y90. This initiated a long-standing period of active and productive research into radiation dosimetry and dose response from beta radionuclide therapy, where she has established an international reputation. It has quite directly led our group into establishing a radiobiology wet lab to examine the effects of radiation on cancer cell lines under controlled conditions. So much is known about the radiobiological effects of external beam radiotherapy, but so little is known about the radionuclide therapies. Cathy has been a contributor to the growing, but still tiny body of knowledge in this area of increasing importance. While doing this, Cathy also found some time to marry and deliver 2 beautiful daughters. She also had been progressing through the ranks to, I think, now brown belt in Brazilian Jiu-Jitsu. She has now been appointed full-time as a senior medical physicist in nuclear medicine at Royal North Shore. She remains, however, in great demand as a researcher, lecturer and teacher. Her input into the treatment of our CERT patients is much sought after by our physicians, interventional radiologists, and even our surgeons, if you can believe it. Cathy has been my colleague now for over 15 years in a variety of roles, and whether I've been her doctoral supervisor, co-author, fellow traveller, reviewer, lecturer, grant writer, or now her student in matters radiobiological, no one could have asked for a more intelligent, balanced, diligent, and pleasant colleague to work with. So it is with the greatest pleasure I introduce Cathy Willowson to you, the Lowenthal lecturer for 2020. Thank you, Cathy.
Thank you so much, Dale, for the kind introduction. Just going to minimise that. So I'd like to begin by, of course, thanking the ANZSNM for the opportunity and the invitation to present the 2020 Lowenthal lecture. It's a great privilege and an honour, for which I'm very grateful for. As Dale alluded to, anyone who's familiar with my history of research would know that my area of interest lies in quantitative SPECT CT. And given some of the really impressive advances that have occurred in SPECT technology over the last 10 years or so, and also the new clinical applications that we can potentially explore as a result of these, I thought it would be very timely to present on the idea of the convergence of SPECT and PET, both in terms of image quality and also image quantification. So if we take a look at the typical output now from our current generation SPECT CT systems, we're capable of producing whole body, fully quantitative SPECT reconstructions. And if we compare that to the current generation PET CT output, I think we can agree that these are now looking a lot more comparable, certainly, than they used to. The nice thing about this is that both of these modalities can now produce reconstructed voxels that are in units of absolute activity. And for SPECT, this is a relatively new achievement. And with it comes some really exciting possibilities and potential use for new clinical applications. So if we just take a brief look at the history of SPECT CT and PET CT, as standalone modalities, SPECT and PET were both introduced or sort of developed very heavily in the late 70s. SPECT took on the role of being a readily accessible tool for rapid diagnostics, and as such, perhaps not quite as much time was invested in developing some of the more advanced processing techniques which were applied quite early on to PET, probably largely due to its heavy focus on research. But despite their separate beginnings, both hybrid PET CT and SPECT CT modalities did come onto the scene in the clinic at the same year of 1999. In SPECT CT, we saw the introduction of the GE Hawkeye system, which, as most of you would be aware, had the notoriously low resolution CT component, and PET CT was brought into the system from Siemens with the first clinical prototype. Over the next few years, we saw some developments here. Certainly the CT component of SPECT CT systems moved towards a fully diagnostic component, and that was introduced by both the Siemens and Philips vendors, followed closely by GE. And PET CT moved towards a fully commercial system, and all three major vendors were on board with that. Now, obviously, there's some fundamental differences between the SPECT and PET modalities. For example, we know that PET has a superior sensitivity when compared to SPECT. This relates to things like the improved signal-to-noise ratio of our reconstructed data. It also means that we can take that sensitivity back to imageable activity in the field of view, which of course relates to things like acquisition duration and also patient dose. PET also has a superior spatial resolution over SPECT. Typically, we'd be looking at about 6 to 8 millimeters for a FDG reconstruction versus something more in the range of maybe 12 to 15 millimeters on a typical technetium SPECT scan. This superior spatial resolution is obviously very valuable when we're considering diagnostic studies, when we're trying to pick up small lesions. In particular, it's very important when we consider the recovery of concentration and counts within those small lesions as well. And as we know, we run into trouble when we start imaging objects that are approaching the spatial resolution of our system. SPECT, on the other hand, also has some advantages of its own. Typically, we're dealing with isotopes that have a longer physical half-life. This can be very beneficial in certain cases. For example, when we're looking at biodistribution studies for antibody mapping or peptide mapping, where we need to be imaging over a series of days following the time of injection. Also, SPECT also gives us the opportunity to perform dual tracer imaging, and this obviously isn't available in PET because we're only dealing with 511 keV photons, regardless of the radiolabel being used. In addition to these fundamental differences, there was another very large difference between the two hybrid modalities upon their introduction into the clinic, and that was that PET CT systems were already at this stage fully quantitative modalities, and so they were producing data that was inherently in units of absolute radioactivity concentration. It took an additional 12 years before we saw vendor-supplied quantitative SPECT CT come into the clinics, and in 2013, this was introduced by Siemens with their expect quant algorithm, initially just for technetium, and then some other radionuclides followed closely behind. And a year later, GE, of course, released their Qmetric software as well. Because of this large lag in the vendor support for quantitative SPECT, I think the dogma has really emerged that PET is a quantitative modality and SPECT is not. Now, certainly today this is not the case, and I think we're very fortunate to be working in nuclear medicine at an exciting time where we have the opportunity to start investigating this new tool and see what it has to offer. So just taking a brief look at the corrections that are necessary to achieve this quantitative data in SPECT and how they compare to the application in PET. Certainly attenuation correction is an absolute must, and nowadays the gold standard of attenuation correction in both SPECT and PET is via the CT-based attenuation correction maps. Scatter correction is very vital. A typical technetium image acquired with SPECT will have photons, about 30 to 40% of those photons will have scattered at least once. So certainly scatter correction improves the contrast of the image, but it is absolutely necessary for any kind of accurate quantification. In PET CT systems, again, we're using a CT-based scatter correction usually. In SPECT systems, we do have CT-based options available, but they tend to be a little bit more complicated, and the preferred method, particularly from the vendors, is to use energy window-based scatter correction. Dead time correction has always been performed in PET for quantification, and it's generally measured in real time at the detector level. In SPECT, historically, it wasn't really needed. However, nowadays, of course, when we're considering theranostics applications for SPECT imaging, where we can have quite large amounts of activity in the field of view of the scanner, we really do need to consider the contribution of dead time to the inaccuracy of our quantification. And that can be performed or measured based on experimental data, and it's generally applied either at the projection level or even as a global factor post-reconstruction. Distance-dependent resolution variation also needs to be taken into account. For SPECT, of course, we have a differing radius of rotation for our detectors depending on our patient study. PET is a little bit more straightforward because we have the fixed ring geometry. When it comes to considering the decay correction characteristics of a given radionuclide and the branching ratio, certainly this has historically not been considered in SPECT reconstructions, but it is routinely applied in PET. And this relates back to our cross-calibration factor that we measure, which really ties in our in-house dose calibrator with the tomograph itself. Finally, once we have fully corrected count data, we obviously need to convert that into the desired units of absolute radioactivity. And this is done using the system sensitivity factor. Now, I think part of the historic reasons why things have been a bit more complicated with the generation of quantitative data in SPECT is that a lot of these corrections are, of course, specific to the energy of the radionuclide being used, which obviously in SPECT this is changing. In PET we have just the 511 keV photons, so things can be a bit more simple. But nonetheless, whilst this hasn't previously been performed for SPECT studies, certainly now in the day and age of quantitative SPECT, we do need to consider system sensitivity measures, and this can be done via experimental data, very similar to how we might measure it on the PET scanner. Of course, these factors have always been contributing to PET reconstructions, and they are inherently included in the DICOM header as part of that rescale slope factor. Now, just because vendor support that allowed the application for all of these corrections has only come onto the scene since 2013, that certainly doesn't mean that quantitative SPECT CT was not being performed prior to that date. And I did just want to highlight some of the impressive work that's been done in terms of in-house quantitative SPECT at various sites around the world. And looking through the literature, there are a lot of examples. This is just a couple of tabular examples summarising some of those studies. But what I wanted to highlight here is that you can see there's a range of radionuclides that have been investigated. It's not just technetium. And certainly technetium tends to be the most simple isotope to investigate. But we have seen lots reported in the literature for other radionuclides as well. And when we consider on the far right here the accuracy of these in-house methods, we tend to find that it is actually quite good. Usually for in-house quantitative SPECT, we'd be hoping to recover concentration measures in sort of large warm areas of concentration to within 5% of the true values. This, of course, breaks down as we move towards hot areas of concentration that are contained within a small structure. And the accuracy, of course, will depend on how the algorithm is taking into account resolution modelling or perhaps post hoc recovery coefficient measures as well. One of the other things I wanted to point out here is that we can consider the different components of the reconstruction algorithm that have been used. And I think this has really been one of the difficulties of when we consider the history of in-house quantitative SPECT, in that there hasn't really been much standardization. There's been a lot of variation in the approach, both in terms of which corrections have been applied and how they've been derived and applied to the data during reconstruction. As a result, it can mean that some of the published data can be quite difficult to interpret and bring into our own clinical context. So I think one of the really great things about having the vendor-supplied quantitative SPECT is that we can now start to move towards this method of standardization, which of course is where we're heading continuously with PET as well. How do you go about performing quantitative SPECT if you don't have access to in-house expertise? Well, there are now a few options available, and I'm sure this will be growing quite steadily over the next several years as well. We can see that 2 of the major vendors do have their own software releases associated with the derivation of quantitative data. We also have some vendor-neutral software available for reconstruction of images from any scanner to allow for quantification of that data. Taking a little look at these in more depth, as I mentioned, in 2013, Siemens were the first to release the quantitative SPECT algorithm, and that was called the SPECT Quant. The method itself uses a NIST traceable calibration sensitivity source, and the idea here is to standardize sensitivity measurements across many different sites and systems, and of course over time as well. It's fair to say that this is perhaps not the most straightforward method for sensitivity measurements. It can be a little bit expensive as well, but it's worth noting that they do also have an alternative algorithm to use, which is their broad quant algorithm, and that really just is based on in-house measurements in the dose calibrator, much in the same way that we would do for our PET systems as well. The reconstructions from the SPECT quant algorithm are, of course, in units of absolute activity, and they can readily be converted to SUV. Originally, it was released for technetium, and then over the next few years, we saw other radionuclides come on board, including, importantly, lutetium-177, which is obviously very applicable for our theranostics applications, where quantitative SPECT is in a bit of demand. The broad quant algorithm that I mentioned, I believe, allows you to add basically any number of radionuclides that you choose to use in the clinic as well, so it has a bit more flexibility. Siemens have also had some sophisticated technology developments in parallel with the development of their quantitative algorithm. So they did introduce a new method for real-time dead time measures at the projection level. And they also introduced the SPECT bone algorithm, which some of you would already be familiar with. And as the name suggests, this is specifically for bone SPECT CT. And basically what it's doing is using the CT as the frame of reference for the reconstruction, and it essentially sucks the counts back into that skeletal zone map upon reconstruction, and it creates a very sharp image, as you can see here, and essentially, I guess, improves the resolution of the reconstructed data. The literature has quite a number of examples of sort of exploration of both phantom and clinical studies using the SPECT quant algorithm, and just using a few as examples of what we generally see in those reports. Certainly there's good accuracy in phantom measurements for not just technetium but other radionuclides as well. Accuracy of our results are generally comparable to PET measurements in phantoms, and there's certainly been quite a lot of investigation of the use of the SPECT bone algorithm to look at reporting of SUVs in bone metastatic disease studies that are performed in the clinic. The GE system differs in that it's using semiconductor technology, so it has the cadmium zinc telluride detectors. As a result, it has an improved sensitivity, and certainly this results in greater speed, and it also has an improved energy resolution over our traditional scanner setup. Once again, the reconstructed data is displayed in terms of absolute activity, and that can be translated into SUVs. I believe the GE software is also part of a broader dosimetry toolkit, which allows for very ready pushing of the data into time activity curves and derivation of residence times for absorbed dose measures as well. Again, the literature is quite similar in terms of the accuracy that gets reported between the two. We've seen reports of good measures of SUV and concentration in phantoms, even within small structures where resolution issues may be an issue. And we've also, again, seen the use of SUV measures in the clinic. Looking at the vendor neutral software that's available, there's two packages, and the first one I'm going to mention is the MIM Spectra Quant, and this is the most recent edition. It's only recently come onto the market, and the idea here is that, as I mentioned previously, we can reconstruct data from any scanner and create fully quantitative output. The reconstruction process uses CT-based attenuation correction, as you might expect. It uses the energy window-based scatter correction. So to use this package, there may be modification of imaging protocols so that the correct scatter window is acquired at the time of the study. It can use a point spread function recovery method for resolution recovery, and I believe this can either be found in a lookup table courtesy of MIM or measured on site. And once again, of course, the scanner specific sensitivity factor needs to be applied to that data as well. Again, this package is part of the broader dosimetry package and the MRT license that's available through MIM. And as it's reasonably a new addition to the quantitative SPECT tools, there's not a heap of data in the literature, but certainly there are examples comparing it to the Siemens XSPECT quantum flash 3D algorithms in a very favourable way. Finally, the last package that's available is the Hermes Medical or Hermes SUV SPECT package. This one differs a little bit in that it uses a Monte Carlo-based scatter correction, and it also has the option for Monte Carlo-based resolution recovery, which is thought to be more accurate for higher energy photon emitters, so your I131, I123, and Y90 imaging perhaps as well. Once again, it is part of a dosimetry toolkit, and many of you may already be aware that Hermes did partner with Olinda, and so it links up to the Olinda exponential modelling software, where we can readily push data to generate time activity curves and patient-specific dosimetry. I also believe that Hermes are currently developing voxel-based dosimetry as well. So there are some sophisticated methods available out there. The literature for the Hermes is quite similar. There's a bit more out there, as I think it was released a bit earlier than the MIM software. But once again, we're seeing good comparability between the various software packages that are available, good accuracy of phantom measures, and the application of SUVs in clinical studies. So now that we're aware that there are several options out there to explore quantitative SPECT, I guess the question becomes, if we consider a typical day in the life of nuclear medicine, courtesy of ANZSNM in this case, how can we go about integrating quantitative SPECT CT? Where does it fit into our clinical routine? Can it help us improve patient diagnostic studies? Can it play a role in therapies? And overall, can it improve patient management and just contribute to a better experience in the nuclear medicine clinic? So I wanted to spend the rest of the presentation exploring some of the more obvious examples of where quantitative SPECT may play a role in the future in our clinics. The first of these, and certainly the most obvious of these, is in bone scans. And anyone who's familiar with the quantitative SPECT literature would be well aware that there's quite a bit out there demonstrating the use of bone SPECT CT using quantitative algorithms. There has been so much interest that the ANZSNM also included a statement in their bone scintigraphy guidelines in 2016, just stating that it is a novel technique. It's potentially got useful applications in treatment response monitoring. However, the exact role in routine clinical practice has yet to be determined. And I think that last point is incredibly important to consider when we're looking at any of the quantitative SPECT applications in the clinic. This is a new technology, relatively speaking, and we need to have a good understanding of what these quantitative metrics mean for our diagnostic studies in general nuclear medicine before we're ready to understand how to interpret these and essentially feed them back to referrers and use them to improve patient management. So that's worth keeping in mind. Regardless of the reconstruction algorithm that's favoured for bone SPECT CT, whether or not you want to use the bone specific algorithm to improve resolution, I know it creates some very sharp images that I believe some of the clinicians are a bit reluctant to trust. But regardless of which methodology is used, certainly SUVs become available. And those SUVs may be useful in characterising lesions, aiding in management of patients, and certainly looking at treatment response and monitoring. I've got a few examples from the literature which I think just summarise nicely what people have been so interested in terms of applying this tool for quantitative bone SPECT CT. There's nice examples comparing bone SPECT CT in SPECT and PET in the same cohort of patients, demonstrating very nice similarity between SUV ratios and good correlation between SUVs. And the really exciting thing about this is that we're seeing SUVs being reported for SPECT studies, not just PET studies, which is great to see. There's examples of using and defining SUV thresholds to show a significant difference between uptake in bony metastases versus benign arthritic disease. And there's also some nice examples highlighting the use of quantitative uptake to predict which patients are likely to go on and present with hematotoxicity or progression of disease following treatment with radium-223 dichloride for metastatic castrate-resistant prostate cancer. So these are all, I think, very interesting applications for quantitative SPECT, and certainly areas that could really see a role for quantitative SPECT in the mainstream clinic in the future. A second area, which I think has actually been a very big driver behind the vendors' interest in quantitative SPECT in the first place, is that of dosimetry. And some of you may be aware that in 2013 there was a European Council directive which mandated that all treatments should be planned according to the radiation doses delivered to individual patients, just like they've always done in external beam radiotherapy, but certainly for historical reasons we haven't really done that in radionuclide therapy. The directive also specifies that the verification of the radiation doses delivered should be performed. And certainly because our radiation treatments are generally speaking using beta minus or electron emitters, they have an accompanying gamma. So the imaging that's required to perform these dosimetry calculations is going to be based on the gamma camera, and it's going to be requiring quantitative SPECT CT. In terms of the role of quantitative SPECT CT for predictive dosimetry and treatment planning, the most obvious example would be in radioembolization. And as most of you would be aware, we use a MAA SPECT CT and whole body study usually to look at the arteriovenous shunting. And there has been some argument in the literature over the last several years about the role of the MAA and whether or not it can be expanded in its capacity to also include taking a look at the lesion targeting within the liver and going a step further to use it for predictive dosimetry. And I think the argument generally is that we have no other tool to do this, so yes, it should perhaps be performed. And certainly there's many, many sites around the world that do this routinely, including us at Royal North Shore Hospital, and it really has become a very invaluable tool in the treatment planning sense. You can see an example here where the centre row is demonstrating the MAA quantitative SPECT CT data that has been converted into a dose map in units of grey based on the planned activity for the time of therapy. And, you know, historically, we have not been able to get any sort of this data out of SPECT studies. So to have that tool available where we can go ahead and develop things like dose volume histograms to pull out some of the more sophisticated metrics to really help guide our treatment, it is very exciting and certainly is putting us more on par with how things are done in external beam radiotherapy. On the flip side, looking at post-treatment dosimetry, one of the areas which I think has really boosted the interest in quantitative SPECT and just dosimetry in general is the treatment of neuroendocrine tumours with lutate therapy. So for patients receiving their lutate therapy, the kidneys are one of the organs at risk, and we like to assess the dose to the kidneys following each cycle of therapy just to make sure that they're not approaching any levels that may result in toxicity, and also so we can help guide ourselves when it comes to future courses of treatment and where to next for these patients. So typically these patients would have 3 imaging time points following the injection of lutate, and quantitative SPECT can be derived for each of those time points. We're then able to use the CT to delineate the kidneys as a volume of interest, push that delineation onto our quantitative imaging, and then go ahead and model time activity curves based on those activity measurements at each time point. And this is an example in the modelling software of Elinda. And that then allows us to push that through to a certain model that matches our patient and derive some estimates of absorbed dose in the kidneys. And this is performed, as I said, at each cycle of treatment, and we're able to then look at the cumulative dose at the end of all 4 cycles. Something that I really wanted to highlight here is the importance of having quantitative data as opposed to what was historically required for dosimetry studies, being just 2D planar data. And what I've displayed here is the results of a recent study taking a cohort of NET patients treated with lutate. I think it was about 80 cycles all up. And these patients underwent the standard 2D imaging as well as fully quantitative 3D SPECT CT. And both of the methods were used to derive dosimetry and absorb dose values in the kidneys. And you can see that the 2D method on average produces absorbed dose measures that are more than twofold greater than what we get with the more accurate quantitative 3D data. So it really does highlight the importance and the need for that quantitative SPECT in any form of dosimetry. On the subject of moving towards 3D data from traditional 2D data, which is certainly what's been available in a lot of cases and a lot of standard diagnostic whole body studies in nuclear medicine, we need to consider how to keep that data familiarity for ease of clinical reporting. So I've got here some examples of 3 time points of imaging, again from a lutate patient, and you can see we've used whole body SPECT for these particular patient studies. So whole body SPECT is one of what I think is the very impressive developments in SPECT technology that has occurred in parallel with quantification. Again, it really makes our data look a lot more similar to the output that we can get from our PET CT systems. And it has a lot of additional use as opposed to just the 2D planar data, where we're squashing our 3D information into a 2D image and potentially losing a lot of that important data. So at North Shore, we've replaced completely the old imaging protocol for our lutate patients. It used to consist of a whole body 2D planar image followed by just a single SPECT CT of the kidneys to perform quantification and dosimetry. We've now completely replaced that with a whole body SPECT CT only, and that corresponds to 3 fields of view of the SPECT. As a result of this transition, the imaging time is approximately halved, which is obviously very beneficial for the patients, also very beneficial for managing clinical scanner time. With whole body data, we have a lot more information available. We can potentially look at whole body dosimetry or dosimetry of organs and lesions outside that renal field of view. Previously, that wasn't available. But one of the other things to consider is that the clinicians no longer have that familiar 2D planar data to look at that whole body distribution. So in an effort to keep that during the transition from 2D to 3D, we've also investigated the idea of reprojecting planar data from the whole body 3D SPECT. And this is an example from one of our PhD candidates, Hyun Ju. On the left, you can see reprojected planar images at various views taken from a whole body SPECT bone study. And on the right here, you can see the conventional 2D whole body scan that's been done on the same patient. So I think this is a very interesting concept, and it keeps that ease of transition in that we keep the familiar data, which obviously is very important for the clinicians who are reporting on the study at the time. I believe Siemens also have taken this idea of reprojecting planars from SPECT data in some of their research software that is now under review. Another area that will most likely benefit from quantitative SPECT in the clinic is that of gallium scans. Certainly a whole body quantitative SPECT CT on infection imaging I think could be very useful. How we actually interpret those quantitative uptake values is a question that's still to be answered and would certainly have to be explored before we look at using those metrics for patient management. There's not a lot in the literature obviously, but I did find an old in-house quantitative method that successfully used quantitative imaging of gallium citrate uptake to successfully delineate between lymphoma and benign uptake. So that is potentially an area of interest as well. But another area where I think we'll find gallium-67 quantitative SPECT play a role is that as a theranostic agent. And gallium-67 hasn't really received a lot of attention in this sphere yet. but I do feel pretty confident that it will be coming in the next several years. It has a very suitable half-life of around 3 days, so it's great for those imaging studies where we want to image several days after injection. It's a very familiar agent for us. We've been using it a long time in nuclear medicine, so the chemistry and everything is well known. And using whole body quantitative SPECT, we could potentially be looking at whole body dose evaluation and perhaps even guiding treatment planning for a matched theranostic pair. So I do think that is an area to watch. Myocardial imaging obviously comes to mind when we consider data quantification. In terms of the classic fractional flow reserve measures, certainly there's a possibility of dynamic rest stress perfusion SPECT, but I think for an organ of the size and considering how rapid we'd want to be scanning these patients, we'd probably be looking at doing that with the cadmium zinc telluride or semiconductor technology. Another area, though, that's received a bit of attention in the literature on myocardial quantitative SPECT is that of the diagnosis of amyloidosis. So it turns out that technetium HDP, which is of course a bone imaging agent, has strong myocardial uptake, which is very sensitive and specific and helps differentiate between the two various types, ATTR and AL. And these generally have quite different survival rates and treatment options associated with them. And to have a non-invasive study to help perform this is obviously very exciting for the cardiologists. So in case you're not aware of what the images themselves look like, this is a case study that was performed at North Shore last year, where a 78-year-old man had severe dysfunction on the ECG. The MRI showed features that were consistent with cardiac amyloid, and he then had a biopsy which was strongly positive for ATTR. He then came to nuclear medicine for a technetium HDP SPECT CT study, and you can see the very marked uptake of the tracer in the myocardium, particularly relative to the skeletal activity. And this is sort of the telltale sign. And I believe there's literature as well that has explored the idea of an SUV threshold as a more definitive diagnosis for this as well. There has been so much interest in the use of quantitative SPECT in this type of cardiology imaging that there is now a Siemens-sponsored ARTNet trial running. It's a multi-centre trial running across Australia, and it's looking specifically at this process. And I believe the PI on that is Stuart Ramsey from Royal Brisbane. So that's really exciting to see quantitative SPECT offering a potentially non-invasive tool to help with diagnostics in cardiology, particularly ironically using a bone imaging agent. So certainly something that we'll probably hear a bit more about in the coming future. Radioiodine scans are, I guess, perhaps a little bit controversial in the use of quantitative SPECT. Obviously, this is a very successful area of nuclear medicine. Historically, the therapy has been very well handled, and it may not need further investigation, some people feel. But if we look at the introduction of SPECT CT over planar imaging, certainly SPECT CT has had a lot to offer, particularly when we're localizing metastases and we're looking at the uptake in those metastases following ablation therapy. So the idea is whether or not we want to go a step further and use that imaging to perhaps perform dosimetry in the thyroid remnant and also metastatic disease to see if perhaps we can get a better feel for whether or not these patients may be overdosed, underdosed in a therapy which I think often pushes them towards a one-size-fits-all approach. And there is an example out of the UK where they have performed 3 time point imaging following ablation. And they were able to find that there was a significant difference between the absorbed dose delivered to the thyroid remnant and also red marrow for the patients that had a successful ablation versus those that had a failed ablation and required further treatment. So potentially an area for quantitative SPECT, certainly in a research capacity as well. The last application that I wanted to mention is really a development in itself that has occurred again in parallel over the last 10 years or so. And that is dynamic SPECT. But if we partner that with quantification, I think it could potentially be a really powerful tool in the clinic. And an obvious example that comes to mind for me is mebrafenib and hepatobiliary scintigraphy studies for liver function. So this is a study that's traditionally done on patients receiving portal vein embolization prior to removal of often quite large segments of diseased liver. And we also perform it at North Shore routinely on all of our radioembolization patients, both before and after therapy. So the study itself consists of a dynamic phase. So we perform the typical 2D dynamic imaging. We're able to then draw some rough 2D volumes or regions of interest to generate through PET-like analysis things like whole liver uptake rates. And then following the dynamic phase, a static SPECT CT is performed on these patients. And that just allows us to record a little bit of extra information, such as the functional fraction associated with future remnant liver and so forth. But if we had fully quantitative dynamic SPECT CT, we could potentially look at voxel by voxel liver uptake rate. And I think this could be really interesting to try to get a better understanding of the liver function at this level, and also how that function shifts after invasive treatment, such as radioembolization. And this data is courtesy of Peter Kench at Sydney University. It's looking at using dynamic SPECT, in this case on a research HIDA study. But you can see over on the left here an example of the scanner moving in what I believe is its fastest dynamic mode. And this corresponds to an entire SPECT study being performed in 15 seconds, which I think is really remarkable that we're at a stage now with our technology that we can actually get a SPECT image acquired in 15 seconds. And in fact, only 10 seconds of that is associated with data acquisition. The other 5 seconds corresponds to the acceleration, the deacceleration during rotation. So this is an exciting development in SPECT, and partnered with quantification, I think potentially has quite a bit of interesting applications and certainly research applications for us in nuclear medicine. Now that I've sort of shared my ideas on where I think quantitative SPECT could be used in the clinic, and how we can go about getting it, I think it's important to look at how we would actually implement it come crunch time. So what is needed for quantitative SPECT to be successfully implemented in the clinic? Obviously, we have to have interest, and I think this interest has to come at the whole department level. It's not enough to be driven just, for example, by the scientists. The introduction of quantitative SPECT will affect all factors of the department. So it will affect the clinicians in their reporting capacity. It will certainly affect the technologists in terms of some of the additional things that will need to be done with patient applications and actually on the scanner itself. And certainly it will also be affecting the physicists in the department who will be looking at quality assurance procedures and so forth. There needs to be access to the appropriate hardware and or software. And I've demonstrated some of the things that are currently available, and I do think we will see these options growing over the next several years. And I think it's also important to have some on-site expertise. It is a new application. We need to be on top of how the corrections are being performed, what's exactly being done to our data, so that we can obviously be looking out for troubleshooting, but also gaining some experience on how to interpret these values and put them into the clinical context. What changes would we see in the clinic? Well, there would obviously be some additional QC procedures that must be performed, and we'd also be needing to do regular SUV checks, just like we do in the PET department to maintain the integrity of the PET quantification. The same sorts of tests would be required for the SPECT system. There will be some protocol changes, and this is where the technologists will be relied upon to be doing things like recording patient weight and residual activity, again, exactly like we would do in PET. And there may be other workflow changes for image acquisitions, such as the acquisition of scatter windows, if that's not already been applied. For the clinicians, there would obviously be the inclusion down the road of more PET-like metrics in their clinical reporting. And I think, yeah, again, it's important to highlight here that we want to get a good understanding of what these metrics mean before we start pushing them into the reports and feeding them back to referrers. What obstacles lie in our way? There's always a few of those. Certainly there's a lot of variability, as I mentioned previously, in the approach to quantitative SPECT. Now we're moving away from that as we have more and more sites accessing vendor-supplied software, and we are moving towards a point of standardization, but this is an issue for PET as well, not just SPECT. We do need to make sure we understand exactly what software is being used, what corrections are being applied, and how they're being applied before we interpret what's being done elsewhere and try and absorb it into our own clinical context. Certainly, SPECT does have a lower sensitivity than PET, and this will be an issue when we move to things like whole body imaging. we need to consider that some of our corrections will break down in terms of their accuracy as we have very count poor data. So it may be that we need to have longer acquisition times. And certainly this is an active area of research looking specifically at this issue of, how low can we go? What imaging times can we get away with so that we still have a good enough signal to get accurate quantification? And that is a very important question and will change depending on the clinical scenario. We also have the issue of the fundamental limitation of the system resolution of our SPECT systems, and this has really plagued SPECT and quantification since the very early days, and we will notice that it becomes more of an issue with the medium energy collimators, which of course we're relying on for a lot of our theranostics work. What are some of the developments to address these? Well, obviously there's constant updating and investigation of new hardware and software to improve our speed of acquisition, improve noise control and image reconstruction and so forth. And I think this will continue to happen in the background for many, many years to come. There's also new image analysis techniques, and these aren't necessarily specific to SPECT. I think this is across all of medical imaging. There's a lot of new and exciting things being investigated, and stuff like automated segmentation will probably play quite a role in the future for certainly dosimetry applications. Resolution, there has been quite a bit of development over the last several years. Certainly we've seen the vendors embrace the idea of the point spread function resolution recovery model, but that can of course introduce its own artifacts. We've also seen Siemens try and address the issue using the expect quant bone algorithm, which is I believe also has its own issues with artifacts as well. So nothing's perfect, but there is additional research going on in the background, and I just wanted to highlight the work of one of our PhD students, Harry, which is looking specifically at theranostics image reconstruction. And as the name obviously suggests, this is only applicable for theranostic pairs. But the idea is to use the higher resolution PET data to help guide the reconstruction and act as a prior during that reconstruction for the poorer resolution SPECT data. And you can see some examples here where we've got a reconstruction, in this case, of a meningioma. And not only can we visualize the uptake in the lesion much better with the theranostic image reconstructed SPECT down here compared to the standard quantitative SPECT up here in the right corner. But very importantly, we actually recover very good counts for that tiny small structure. So that's a big step in the right direction. And there's another example here using the IEC Phantom. So all of these developments are pushing quantitative SPECT further down the path towards convergence with PET. And obviously PET has had some exciting developments of its own. We've seen PET MR come on the scene and whole body PET, which I think could potentially make quite a big impact clinically. And it's really enjoyed quite a bit of time in the limelight. And the question is, can SPECT stay this course of convergence and perhaps steal that limelight for a bit to have its own time? And I believe it can. And certainly in the next few years, we're going to have the pleasure of finding out and taking a look at exactly what clinical avenues this opens up. So I'd just like to finish up by acknowledging Dale Bailey. As you would have gathered from the introduction, Dale and I have worked together for many years. He's been a mentor of mine in medical physics for a long time, and he's always been incredibly generous with his time and also his expertise in helping me learn, and I do really appreciate that. Also, the Department of Nuclear Medicine at Royal North Shore Hospital. This is a really innovative place to work. There's a lot going on. It's always very exciting. There's a fantastic group of clinicians, scientists and technologists, and I'm very fortunate to be a part of that. And finally, James Anderson for the SPECT versus PET animation. So thank you very much for your attention. And as Karen indicated earlier on, if there are questions that are able to be pushed across the virtual platform, I'm very happy to answer.
Thank you so much, Kathy, for an outstanding presentation. The floor is now open for questions, and I see that one has come up through the Q&A box from Prue Lamerton, and she has asked, can you comment on uptake as a whole in the myocardium compared with individual regions of increased uptake for prediction of amyloidosis?
That's a very good question. The short answer is no. We've only done the single case study here, at North Shore Hospital, and it may be that it's not until we get more results from this trial that's occurring that we can better interpret that. I know there's indications in the literature talking about an SUV threshold of 1.2 to successfully differentiate, but how many studies that's based on and sort of the specificity of that value, I'm not sure of.
Thanks, Kathy. Prue, your microphone has been unmuted if you wanted to comment further. Otherwise, does anyone else have any questions?
I have one, Karen. It's Daniel Badger here. Hi, Kathy. Great talk. I'm always keen to hear your talks. It seems to me there's always a bit of a chicken and an egg problem with these sorts of new things, where, especially in instances where there's maybe a little more time or radiation exposure for the patient when you do a higher quality scan, but the physicians don't really know what to do with them yet. So I've had kind of these questions of, can we do dosimetry? I'm like, yes, we can. It's a lot of extra work, and the vendor supplied stuff is makes that a bit easier, but it's also more time and more dose potentially for the patient if there are more CT scans. But then the physicians don't know what they're going to actually do with the dosimetry if you do it. So then there doesn't seem to be a good reason to do it. But until they actually get the dosimetry to play with, they don't know what the value is. Have you any solution to that chicken and egg problem?
Yeah, I know what you mean, Daniel. I think that's why it's important to realise we're really in the phase of developing the groundwork that needs to be done to use quantitative SPECT in the clinic. And like I said in my slides, there has to be interest at the department level. You know, I think you mentioned the idea of it takes a lot of time. It really can take a lot of time. And I think that actually reflects on the evolving role of physicists within the department. And, you know, it will depend on the facilities that are available and so forth. But I think this is an area that we're going to see medical physicists in nuclear medicine really start to embrace, and it will become, in some cases, quite a large part of their job description. In terms of the additional scanning that's acquired, like I said, it often can reduce scanning time. So I mentioned that example of the lutate patients. It really does depend on the department-specific protocols that are in place. But, you know, we've got the very low dose CTs available now, and that's all that's required for dosimetry. We don't need the high dose fully diagnostic CT by any means. For segmentation, depending on the area of interest, we might need one of those, but often this is already available in, for example, cancer patients has already been done over in radiology. So in terms of the dose, you know, it's a very cohort-specific application and question that you're asking. But I don't think that needs to really get in the way of things. And the other point you mentioned is, yeah, how do we use these metrics? And you know, we're obviously reluctant to yet. And I think that's a good thing. I don't think we should be too eager to report these values if we don't really understand them ourselves. And I think, again, this highlights the importance of vendor involvement, because now there's more of a standardized approach. So we can get things like multi-site trials up and going. It's a bit easier to compare, you know, the results I get here to your results in Adelaide, and, you know, pull together our data so that we can understand these things a bit quicker with larger patient numbers. So I think it'd be great to see more and more departments getting on board with exploring these and exactly interpreting what they mean. I think will come at the broader level when we pull together our data with other centres.
Thanks, Kathy. Kevin London has a question. Kevin, you are unmuted.
Thanks, and Kathy, fantastic talk. I just had a question about departments that may not have as high level physics support as Royal North Shore is spoilt to have. Would you regard the vendor SPECT quantitative products available at the moment as being quite sufficient to sort of move forward with clinical research projects? And maybe even if you could comment on the different vendors' ability to provide some research support in that area.
Yeah, that is a good question because obviously, yeah, physics support varies a lot across different sites and also available time to input into that development. I think, the vendor supplied software is certainly very adequate to produce quantitative images. And in fact, if you look at a lot of the literature, particularly that came out immediately after the Siemens release, a lot of that exploration of bone SUVs and stuff, there's no physicists necessarily on the list of authors. It's really had quite a strong clinically driven interest. So I think it is fair to say you can do that. Obviously, having a good relationship with the vendor is very useful. Implementing the procedures that are involved to set this up, it does require a bit of work, and certainly you want to have some maintenance in terms of your quality control and so forth. So if you have a PET department where that sort of stuff is being done, I don't think it's going to differ very much to those demands. So in that respect, a physicist or a technologist who's familiar with SUV checks and so forth, I think could probably handle that quite well. Also, there is obviously the vendor neutral software, and that is really set up to be as easy as possible. And I don't personally use it, but certainly we've used other products from both MIM and Hermes, and generally speaking, the support available is quite good for those as well. So I don't think it has to be a barrier if you don't have a strong physics team available. But I just think it perhaps might need to be thought out a bit carefully as to whose role will be what exactly. And again, get some good liaising going on with the vendor itself.
Thank you, Kathy. Are there any further questions or comments? If not, I'd like you all to join me in thanking Kathy for an outstanding presentation, and I will hand over to Dale, who will award Kathy with the Lowenthal plaque for 2020.
Thanks, Karen. In these times of social distancing, we have to take different approaches to making presentations like this, but I just wanted to remind everybody the Lowenthal lecture is in recognition of the work and the contribution of Gerhard Lowenthal, who was one of the first newsletter editors of the journal in Australia. And the remit of his named lecture is to speak to the radiation science and measurement and biology. And I think Kathy has really covered that incredibly well. Now, often this award is given to people perhaps in their twilight of their careers, perhaps who have spent a long time building up a reputation and are starting to slow down. That's not the case with Kathy. This is a rising star. So I'm pleased that we've chosen Kathy this year to receive this award. So hopefully you can all see, there's the plaque. I can see myself now. There we go. And congratulations, Kathy. That's a fantastic lecture. And
Massive.
And we've got some flowers for Kathy as well. Yeah, Susie, you can. Just while we're doing that, I'd just like to thank the team locally for the production and the work they've done. Ali from our department, as well as Susie and Alan from the Translational Cancer Research Centre, who have helped with so much of the AV here, and also the remote team of Daniel and Raj and Rob and Karen to help bring this together. So thank you very much.